There's lots to say. For those who know me, such as Karen, they know I could stand up here for about 3 days and talk about this stuff. And considering the hour of the night and what you've heard, the good news is I ain't going to do that, all right? My brief, I think, is to convey lessons that we've learned, because we're about 12 months ahead of where you are, that may be of some value in the process that's going to happen here for you. So our health pathway work is really a journey, and we're still actually early in the process when you think about the kind of work that Carolyn presented there. And health pathways is a bit of our work at improving the system, but the question I asked Carolyn, I think it's a fairly integral component because it's a good backbone. We've got other projects going on as well, but I'm only going to focus on health pathways. And the challenge always is to integrate the various programs that are there. And again, health pathways is one of the things which helps us to do that. In summary, I think health pathways helps us to unravel a lot of the black boxes that I call the hospitals and the community services. From my point of view as a GP, I don't know what goes on in the hospitals. I don't know how to get into the services. And health pathways offers us, as we build it properly, a way of actually unravelling that. But similarly, the specialists don't necessarily know about other services in the hospital, or sometimes about their own services and the processes that are involved, or the problems that are involved in the delivery of their services. So we've actually seen some good addressing of those kinds of things as well. So I've said, my quick note here is changing and sharpening both the hospital and GP services. I think that's really one of the kinds of things which is actually occurring. The feedback button, just to quickly comment on that, we've got our clinical editors sitting at the end of the feedback button, and if we get some data that changes, like just for example, phone numbers or issues to do with referral pathways that need simple tweaking, that's not an annual review. That's a message that comes in, and that's added through onto the website within a day or two. So there's quite a dynamic sort of, call it small-scale feedback that's going on, as well as the general review process. So I've got lots of things to talk about. On the bottom dot point here, I'm aware of that as far as where this is concerned. Experiences and Outcomes from Australia, a wonderful title, the Australian translation of health pathways. But you guys are doing it well already. I've got lots of things I can talk about here as far as what's going on, but I wanted to really focus mainly on the Western Sydney experience and just on a couple of lessons from that. Health pathways is, as we say, systematic way to improve the care between hospitals and general practice. We call it an online support tool showing locally agreed information about how to manage conditions and how to refer patients to the system. And because it's got a greater agreement and clarity about how to do this and who provides where and when, that's what we see as behind improving the care. There's lots of these slides which we don't need to spend time on. It's a whole of district approach, so it's an integrated kind of approach, trying to improve the delivery of care across the acute and primary care divide. But it's both a process, that means looking at what we're doing, and an outcome, that's the website. So there's the two different bits and pieces that go on. New Zealand, as best as I can tell, Canterbury, started with a blank slate. So they were doing a lot of evaluation of their process and documenting it. What we've got here in Australia is that we've all been given 600 plus, 540, 680, whatever number you come up with, pathways that are there already, okay, which we can actually put up, and I think most of the regions who've decided to do it, as you've said, have put them up there. The New Zealand pathways are up there. So we've actually got kind of the development already up there, and so we've got a different slant, if you like. We're not redesigning and documenting. We've got documents, and then we're going to take selected bits of that and start doing some redrafting and redesigning. That's the kind of the process that we've taken in Western Sydney. And it's trying to match the triple aims. The three triple aims: improve health of the population, enhance the patient experience, and reduce the cost of care. Now, as you've heard, it's implemented in about 12 sites around Australia with various starting dates. Hunter, New England, I think, were the first. And as far as I'm concerned, because we've all chosen to effectively adopt the New Zealand model, what we call this is really starting with a textbook. If I brought Harrison's or some textbook to you, you would read it, you would use it, but you would interpret it. You would adjust your care based on your understanding of that, because it's not going to have specific Australian drugs, units, pathways and so on. So that's our justification for seeing the New Zealand pathways up there. Although I heard the comment from Graham say it's not a textbook, that's true, but I treat it up there at the minute like a textbook because there's useful information up there in all of the pathways, but it's only when you start to Australianise, that means put our drugs in there and our MBS and our PBS, and localise, that's put our local referral pathways in, that it gains even more value. So you can look at what's there at those different kinds of levels. Now, the Australianisation seems to be able to be effectively done by one or a small number of regions, but the localisation, focusing on the referral stuff, primarily needs to be done in each of the regions. In New South Wales, the New South Wales Agency for Clinical Innovation is supporting our implementation, particularly through the evaluation of the processes as well. So I just needed to say that's there. Western Sydney. Western Sydney is a small place. Western Sydney depends on who you talk to about what it is. Western Sydney Medicare Local is actually Blacktown, Parramatta, Holroyd, Auburn, and one more, and Baulkham Hills. Those LGAs, that's it. But that population there has got the best part of 1 million people in it, like that, and growing. We've got five public hospitals and 2 private hospitals. So it's quite interesting, the patient flow, and particularly when you think that we've got, no one respects these boundaries. So people who live here come here. That's funny, that, you know, all right? And that's a very interesting challenge for Western Sydney Local Health District and Western Sydney Medicare Local, because if we're developing our work for the things that happen within the LHD and people come in from outside, that makes for a challenge. Nonetheless, that's part of what we face. We actually are also at WetWest, which is the company that runs Western Sydney Medicare Local. We're also a GP training organisation, so we're the only organisation in the country that has actually got both of those contracts. But our GP training organisation, just to make life difficult, covers a bigger area, like that. So here is our spread of our training practices there. And we've got about 70 registrars coming in the cohort for next year. So we're training a lot of young doctors. And I raise that primarily because we've taken the approach that the extended skills term, I should say, for the GP registrars, their last term effectively, is on offer for some of our registrars to become GP clinical editors in the process. And those who've done it so far have found it to be incredibly valuable. And we found it valuable for two reasons. One is a business reason. They're cheaper, all right? But the second is a real reason. They've just come out of these hospitals. They know the system. They know the process. They know the people. They're actually making our life of unravelling the black box of the hospital a whole lot easier. Now, we've got some good operational relationships between our Medicare Local and our LHD, with common health priorities and a joint operational plans and a partnership advisory council and so on. So our health pathways work is constructed within that environment, as are some of the other projects and so on that we have. We've chosen to focus on chronic disease as our main pathways we start with, for all the kinds of reasons that happen in lots of places. These graphs tell us that our chronic disease is outstripping our population growth and loading our hospitals and increasing or challenging our preventable admissions. The areas of preventable admissions we need to address are those with chronic disease. So how we do this is we have got our health pathway team underneath the executive sponsorship of the executive medical director in the LHD. We have a steering committee which comprises representatives from the LHD, the Medicare Local and the Children's Hospital at Westmead. We have an operations committee under that with clinical leads from both the Medicare Local and from the LHD, and program managers and other representatives, and a senior clinical editor. We have 3 clinical editors at the minute, 2 are GP registrars. We've got 2 more GP registrars lined up to come on as we expand our process. And we've been working through working groups, which I'll talk about. So in the areas, chronic disease, that we've decided to work with, we've said we'll do working groups. So we've had a diabetes working group, we've had respiratory working group, and so on. We'll talk a bit more about that. This complex slide is trying to document how we actually get these things signed off and who's got what responsibilities within the process. Effectively, once the work is done, it's pushed up the chain. I've got another slide demonstrating that as well, but we've tried to outline here some of the duties and responsibilities for the various people in the process. We've got 2 sites like everybody, so we've got our live site, which contains all the New Zealand work except what we have already localised is replaced. We've also got our draft site. The draft site is only available to people in the working groups. The draft site is the live site, except that there are some places within it where the New Zealand pathways are replaced with Australianised pathways from other Medicare locals or other regions already in Australia, because they're parts that we're going to start working on. And we've also got the pathways we're actually working on in the current working group or groups there on the draft side as well. So our working group is our central component. We take a clinical stream. We started with diabetes. We've done we've done cardiology. We're working on respiratory. We've done some orthopaedics, and I'll show you a few of the others that we've worked on so far. And in the working group, we have 2 processes, and we've changed this to, between the different working groups. Sometimes we get the clinical editors to look at the information first and make some tweaks and some changes and some documentation, a bit like you're doing here in ACT, where you're doing some work firsthand. Sometimes we take the pathways to the working group because we want to get the specialists and GPs to have conversations about the care delivery and the care delivery processes before we actually start to document. But whichever of those starting points we have in the working group, we're out to work on best practice guidelines, local referral information, and look at potential redesign opportunities for the system. So we've got those 3 different focus in our mind in what we're going through when we are actually working through the pathways. And lesson number 1, when you start at least as well on this one, on referrals. Because if you're going to document what's happening in your system, if you're going to change it, you need to document what's there. All right, and if you're going to document what's there, start early, because quite often they're very complex systems and you really need to start recording what they are. It's interesting when people start working out what's actually got to be done to get the patient into the service, and they start going, really? Is that what we've done? You know, and it starts to lead to redesign opportunities, even simply at the referral point. We've documented our pathway process, so this is talking here about the working group meeting and then the GP clinical editors and subject matter experts starting to make some changes to the pathways, how then that information is then published on our draft site before the whole working group then has a look at that first cut, and then more changes are made, then the second version is put onto the draft site, and then that's, if you like, voted and morphed. Usually not much more change goes on before it then is put up for consideration to go to the live site. And that consideration to go to the live site requires some specific sign-off. And the sign-off process, again, is convoluted in our place, because from the point of view of clinical governance, we actually want the specialist input to confirm, if you like, that we're talking about best practice, but we want the GP input to confirm that we're talking about real practice and usable practice, okay? And that's an interesting set of tensions, but you'll see that I've snuck into the process after all of the specialists have had a go at everything here, starting there and working all the way down like this. I've snuck another review from us into the process here, because we are still keen that anything that goes up there is usable and useful to us in general practice. That's a very important part of the pathways that goes up there. So our journey so far, we've got 52 pathways, but that's many more pages than 52. We've got another 120 odd in draft. We've worked across 7 major clinical streams so far, plus what we've called general practice focused or clinical editor working group, things like lifestyle, things like preventive health pathways, things like how you use the MBS and the PBS, like diabetes cycles of care and that sort of process. We have also done some attempts like, again, has been cited as examples in a rapid localisation, which means not going to working groups, but actually just documenting some pathways, like how sexual health matters are managed. And that's our front page. And what we've tried to do on our front page is to make it an information sheet as well as an entry to all of the data that's there. So we've got our most recent work that's there. We've got our working groups that are in process here and the upcoming working groups down here. Plus we've got some other information which is accessing into things to do with the Medicare Local and the LHD. One of the most useful sites that we've actually got is this one, the useful websites, because embedded underneath that we've got a whole series of organisations and referral points and just health system information that practitioners can make use of. One of our favourite slides, health pathways is not the answer, it's part of it. Health pathways fits in with everything else, and when you tweak something, sometimes you can put other bits at risk, so you've got to take it into context when you're doing things with health pathways, which is what I've said there in words. It doesn't operate in isolation, it's part of our whole development and redesign. So what sort of lessons have we learned? Now this might build in an interesting fashion because one of my staff put this together today and I've then gone and changed the order around. And I didn't realise they'd done a build slide on this one, so we're going to get this will come up in an interesting scatter across the slide here, but nonetheless. Okay. Work group focus. Planning and pre-meeting essential. If you're going to have a successful working group, then you've got to plan it out and you've got to do some pre-meeting with the clinical champions. That's a really important thing. Don't expect that you can bring together 7 specialists and 6 GPs and some other allied health people and sit them down in a room and suddenly something's going to happen. You've actually got to work on that and plan it out and sit down with clinical champions before you get to that. So clinical engagement is critical. And there are no right answers. There's actually different ways you can do this. And we've actually, through our working groups, we've delivered different processes and different strategies to come up to the end. I'm sorry, it's going to build all over the place here. There's another lesson to learn, which is do your slides yourself. Having a GP focus is critical. Specialists do want to be engaged though, but having a clinical champion among the specialists is really a valuable thing. And in our area, having the heads of department from the various areas supporting what goes on certainly speeds up the process. Engage the GPs, get the right GP clinical editors, be flexible in how we do it. I've said you can do subtle changes of approach and there's no right answers. As far as localisation is concerned, localisation, that is taking the data that's there and assessing it against the kinds of processes that we've got already in the area, helps us to point out and identify redesign opportunities that we've got. And referral information is crucial, as I've said. It's actually, the medicine part is generally agreeable, but the localisation and the referral information is really the important bit. We're finding usage of the site slow, but steady, and we are focusing on having clinically sound information there and constantly promoting it to be taking up the use. We've done surveys beforehand asking GPs if they think that referral processes and referral information is available and there, and basically they say, well, no, it's not. And do you think that something like health pathways, which would give information available to you, would be useful? And they say, yes, it is. It would be a very good idea. So what have we provided? We've provided access to health pathways in lots of different ways. Clearly, you can have it on your computer, on your desktop, you can have it on your iPad, on your phone. We've embedded it, well, you can embed it very simply within the clinical management systems. I use Medical Director at my practice, and that's got some little tabs down the bottom that you can have your favourite referral web pages, and so I've loaded health pathways as one of my favourites on the screen there. There's different ways you can do that, but by gosh, that's made a difference for me because I've gone to look up, just like you gave the example, Martin, you know, occasionally something comes up and you think, wow, I wonder what else could cause that. Click, 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 search. There's 2 more things I didn't think about. Even though it's a New Zealand page, as I said, the medicine is still good. So you had a quick flick through. That didn't come out like I wanted it. Are we recording this? Just go back on that. Even though it's a New Zealand page, the medicine that's there is still good, but the local, I should extend it on, but the actual referral information is something that we have to tweak around. So you can still look at the information and get the medicine from it, even if the referral information doesn't help. We have focused on getting clinician engagement during pathway development, and we've got an overview of some use. So we're tracking with Google Analytics. So this wonderful slide up here tells lots of different pieces of information, but it says that we've got 1,000 users over the course of the time that we've been there. They've seen 36,000 pages. 3/4 of the users are returning visitors, which is really good. They're on 8 pages or so each time they're on a session, and they're on for 7 minutes, so there's still a lot of exploration and understanding for what's going on there in the system. So we're pretty happy with that. You can see little spikes along the way, and some of those we can tie into some of the promotions that we've done. We'd like to see the Graham figures, like the 1 million users and all that kind of thing, but we expect that will come with time rather than anything else. We can track which pathways they're looking at primarily. The top ones have been the diabetes pathways, because that's the first stuff that we've had out there. We can track who's contributing to them. So we've certainly had an array of GPs and specialists who've been involved in the pathways that are up there on site already. And we're communicating in lots of different ways, which is one of the other lessons that I think Graham raised, that we're actually promoting the health pathways out in lots of different ways. So it's on our web page, on our home page, it's in our email and newsletters that we communicate out to our members. We focus on specific health pathways events, plus we put health pathways into other events that we have. Our practice support team are talking health pathways when they're visiting. We have it in our education sessions. We've used it for our GP registrars. I've taken it into workshops with our GP registrars and I've said, here's 6 orthopaedic problems for you to solve. Go and find the best practice. And I've then used them to work on our draft orthopaedic pathways and give us some feedback about that as well. So I had 50 registrars at that time actually working on my orthopaedic pathways. So it was an interesting mix because they were learning, but they were also being able to feed back information about what was there within them. We've got some feedback, a couple of interesting comments from our specialist, Peter Landau, who's senior within the organisation, likes the links that have been developed. Gary Chook, who's in relation to the aged care service of the older persons pathways that we've developed. Very happy. I think the process of localising has allowed us to understand the context, limitation and challenges that GPs face in their practice. In other words, there's a bit of awareness across the specialty and the general practice divide about the complexities and issues that are being faced on either side of the deal that's there. Again, that's our front page, and for the time of the night, I'm not going to go on with anything more, but if you click through our page, you'll find, for example, work on managing diabetes. You'll find on other areas that you'll still go to our New Zealand work, and that's how we've coded the New Zealand work. So we've actually put a colour onto it to make it more clear that this is New Zealand work. We use some of these, like managing newly diagnosed diabetes, in our registrar learning sessions as well. That's actually quite valuable for them. The COPD is highlighted because that's the current working group that's just in the process of taking these pages and working on them. That's from our draft site, so similar to what you've seen here for draft sites. It has got the warning about this plus the draft up the top like that. And I've got just 2 more screens on referral. It's really important to work on referral. If you're going to put a page on the live site and you haven't worked on referral, that's pretty silly. I actually blocked posting some of the cardiology sites that have gone through all of that long chain of approval processes, and they got back down to me, to my useful and usable test. And I clicked through the various things, beautifully constructed cardiology advice, and you click on the referral, and if there's a problem, you had to ring Christchurch. And I thought, probably not the best option just yet. So we sort of called that one off from being posted until the referral work was there. But what we've actually been able to see, the diabetes one helps with this. What we have worked on is that for each clinical stream, we don't embed the specifics of the referral within each of the pages. We create a referral page for that stream. And so we refer then from all the various components of the clinical stream to the referral page. It makes it so much easier to manage that and to bring that together. And what the diabetes guys have been able to do, certainly at Blacktown Hospital already, with this and other work that they're doing in redesign, is free up a lot of their clinic space, because we've been able to move some of the long-standing chronic stable type 2 diabetics who were just the recurring visitors to the service. We've been able to move them out and free some of the capacity already. So this was the first thing we started working on, and we've actually seen some positive in the change in how we can do things in Western Sydney. So that's a quick rush through, just to get a bit of an idea. There's lots of lessons that we have learned, and I'm happy to speak with Martin and David, offline as well, about some more of the lessons if that's of value. So thanks, Ian.
Questions?
Yes, we're very pleased here that the ACT and New South Wales have joined together. This is a bit of a first, I think, to be doing something across a real border, not just a Sydney local government border. Have you got any comments or tips on what we can do there to help? Because these referral pathways may be quite different. For example, mental health patients in Queanbeyan are not allowed to cross the border into ACT. It's almost legislated against.
Yeah. I suppose I'd have 2 answers for that. The first one is take a patient focus. Don't take a system focus, take a patient focus. Have a look at the patient journey. And so describe the patient journey, try to solve the patient journey. And if the patient journey, if the problem is a real strong bureaucratic issue in the patient journey, then there's a redesign opportunity that's arisen from what you've actually identified. But our process here is we try to document what goes on first of all, because that, as I said, unravels the black box. I can't remember. It's too many years since I've been at the hospital and they've changed. I don't know the processes anymore. So it's nice to look it up. So there's the current journey, and then the powers that be can look at the journey and say, that's a bit silly actually. What can we do about it?
So do you think it's best to have 2 pages, one for New South Wales and one for ACT in the circumstances? More on the one page, when you're talking about referral pages?
Can I answer that?
Yeah, go ahead.
The way that we construct the pathways, which is, we've even started to move on a little bit since some of the other regions have been localising health pathways, is we actually take the name of all the providers out of the pathways, and we only describe in the pathway what the patient need is. So if it's non-acute mental health assessment or acute mental health assessment, then you click on that, and behind that sits a page like the referral page there that describes all of the services that can provide that patient need in all of your region. so right throughout southern New South Wales and ACT. So if you keep the pathways generic and you only ever describe what the patient needs and not who's providing it, then you can put as many providers as you like behind that click. So that's the way that this will be able to be done across your two regions without ever altering the pathways.
Some more questions for Michael. I know it's very late. Oh, lots.
Thank you. Just interested in your thoughts around, if you're thinking about one system that includes the private sector as well, and we've got a pretty significant private sector within the ACT, and coming back to some of the points earlier around standardisation and how do you get that happening within the private sector as well as the public sector, and really just thoughts and reflections on that.
I can think to both the diabetes and the cardiology working groups. The players in those were the leading clinicians across the LHD in those areas. And I think almost to a person, they had private appointments as well as hospital appointments. So we were reaching a little bit into the private world by engaging the public, the hospital physicians anyway. But then we also specifically reached out to the community of private providers who were in the area. So diabetes, for example, up here on screen, you can see at the bottom of screen down here, that we've got links through to private endocrinologists as well. So the notion here was to manage the medicine on other pages, put, as I think we saw in some of Graham's work as well, that private referral is one of the options that's available for you, and here's how you can do private referral. But what we've actually said, just to go off track a little bit, what we've said is if you want to refer to these people, this is the kind of information, and it's embedded, probably not on that screen there. Oh, here, it's in this part here. This is the kind of information that we want you to deal with, first of all. We want you to provide this information through. So whether it's going to a public or a private person, by improving the amount of information that the practitioners actually produce and send through, that seems to help the system anyway. So we definitely have got the private guys in our mind on this, and we're actively going out and engaging them at the clinical streams level.
My question, it seemed like the New Zealand system was gathering a lot of data to analyse the system as a whole. Is there any way that the system provides information back to a GP on their particular practice? I'm thinking like we have to do the QI, whether the quality improvement measures are just system-based or whether they would be back to the GP in practice.
One of my first comments was that this is a component of lots of other bits and pieces that go on. And what we've so far decided to do is to make this effectively like an online, call it textbook or advice service, rather than to be doing a whole lot of monitoring and measuring embedded within this. There's other systems that can do that. The more complex you want to make this system, the slower it is to implement those kinds of things. So we have not chosen to do much of that within here. At the moment, that simple Google Analytics is about the level of measurement that we've got for here.
Addressing the links to private practice, how do you link to allied health people? Do you use the websites like ADA, the Dietitians Association, ADEA, Find a CDE?
There's two answers to that. Yes, we definitely do those, both in that useful links thing on the front page and also down the, usually down the bottom here in the referral section and the appropriate pages. We've got ways to get out to the allied health people. So that's one way that we deal with it. But we've also embedded health pathways within our electronic shared care plan. We've got a product that's an electronic shared care plan, and we've embedded health pathways in a context-specific process within that. Our electronic shared care plan is meant to be the way that we are actually linking out to our allied health people, and we've got our allied health people identified within the addressing within our electronic shared care plan. So we've sort of put links in different parts of the system to do it.
How are we going?
I think at 9:15 they're flagging, as I am.
Well, look, Michael, thank you very much for coming down from Sydney to talk to us tonight.